Hi, my name is Pat Casey, and I am on Facebook Live for the first time. In fact, it's my first time on Facebook, so I'm a little bit nervous about this whole situation. It makes me feel like what a patient goes through. It also feels strange to not have a mask on. So anyway, welcome. Concord Orthopaedics, I was just going to say a couple things about it because we get some questions about that. Concord Orthopaedics is open. We are seeing emergent and urgent things. So we are doing that. We're trying to social distance. Everyone's wearing masks in the office. We're trying to be as safe as possible. Obviously, everyone out in the real world is trying to go through that as well. So we still have an AIC, which is an acute injury clinic, which is open for people who have acute needs to walk in. Obviously, calling first can sometimes be helpful to figure out what's the best role in terms of walking in or having a scheduled appointment. But anyway, it's great to be here, and thanks for tuning in. So someone just sent a question about what are the common things that I do. I work in the sports medicine department. There's a few people in my department who are doing that as well. Dr. Moran, Dr. O'Connor, Dr. Higgins, and Dr. Baselli. And we take care of a lot of shoulder and elbow problems. We take care of knee problems as well. So ACL injuries, rotator cuff injuries, biceps injuries, those are all things that we do fairly commonly. We obviously, it can lead to an operation, but a lot of patients don't have operations to start with. A lot of times we try non-operative means. I get asked that a lot. All you do is operate? And the answer is no. At Concord Orthopaedics, there's a lot of things, physical therapy, injections, things like that we do. Another question, baseball season. I'm not an infectious disease doctor. People are asking when the baseball season will begin. The baseball season is, we take care of the Fisher cats and some other things. So your guess is as good as mine in terms of when professional sports and minor league sports will start. I think not for a little while because of the social distancing world, but that can obviously change every week. So I'm trying to read the scrolls and the questions, so if I'm a little bit slow, I'll apologize for that. In terms of, I got asked a question about high school athletics. High school athletics, I think this spring has been canceled, obviously, because of the social distancing. Hopefully it will resume in the fall. Again, part of that is subject to interpretation and when things change, but we will try to get that ball rolling as soon as possible. I have two young kids at home, 6th grader and 8th grader. I know they're going stir crazy without the sports. The sport they're doing at home is wrestling with each other, which is not a great use of their time or our time trying to referee those. So, question: what is your favorite diagnosis or orthopedic injury? I guess I would say my favorite diagnosis is probably the one where people get better soonest. So there are some, ACL is a great operation. That's one of my favorite operations. It takes patients a longer time to get well from that. Sometimes like a loose body in the elbow, which is if there's a piece floating around in the elbow causing people to get their elbow locked or their knee locked. Sometimes going in and removing that, they feel better almost the next day. So doing that is very satisfying both for the patient and for us. I like to fix acute tendon injuries, I would say. So when people rupture their biceps or their triceps, again, they go from being very weak, having a very hard time moving things, to being able to be more functional. This week I just had a firefighter who was out doing his job and ruptured his biceps, and so fixing that was satisfying, hopefully for him as well as for me in terms of that. He's got a little bit of rehab ahead. I got asked another question, what other tendon injuries are common? So rotator cuff is probably the most common injury we see. The rotator cuff, I actually brought a model here. I don't know how well that will show, but maybe I'll hold it up here. This is a shoulder, sort of like my right shoulder here. So this is kind of the ball, and this is the socket. This is the collarbone. And there are 4 tendons that run from the socket to the ball. And those are known as the rotator cuff tendons. The rotator cuff tendons are help us lift our arm away from our body and help us do overhead activity, throw a ball, things like that. And so that's probably the most common tendon injury we see in terms of, for the shoulder. The pectoralis muscle is also a big muscle people know from bench pressing and from weightlifting. That is sometimes gets torn. And so I guess I would say in terms of what's the most enjoyable surgery, obviously when patients do well and they get their function restored, but I would say ones that they get better faster than slower. I got asked the question, how long is a full recovery for an ACL surgery? So the ACL, I'm going to actually have a model, I have a knee here too, so I don't know how well that projects, but this is if I move the kneecap out of the way and look into the knee is, this is the femur or the thigh bone and the tibia. The ACL is this white structure in the middle, and people can tear their ACL skiing, playing basketball. And so to fix that, we reconstruct that. And to reconstruct that means that we have to drill holes and create a new ligament for that. And it takes about 6 weeks on crutches for people to get off crutches and to start walking. But it's a long time before they get back to normal. I've had knee surgery myself. I've been through something like that, not exactly like that, and it took me a good 10 to 12 months. So I tell people return to sports somewhere in the 10 to 12 month, 9 to 12 month range. Usually by 6 weeks you're walking on your knee and you're feeling better, but that doesn't mean you're completely ready to start playing sports again. You can usually start to jog around the 4-month mark or so, but besides that, it just is a process that the body takes time to heal. Also got asked a question about rotator cuff surgery, how long that takes to improve and get better. Rotator cuff surgery is similar to ACL surgery in that I tell my patients it takes a while. They're in a sling for 6 weeks and they have to go through physical therapy. They don't start raising their arm over their head usually for 3 months or so, and they're sore and achy for about 6 months. That does, again, get better and better for them. But it's funny, one of my childhood friends, his father, who's a veterinarian I operated on a few years ago, and I said to him, believe it or not, you'll raise your arm again. And he was around the 6-week mark after surgery, and he said, I choose not to believe it. He says, I feel like I'm in cement and it'll never move. But it eventually does move. It eventually does get better. And so that time frame takes a while. That I would say the one thing people underestimate, both patients, coaches, athletic directors, is sometimes the time it takes to get back to sports and back to playing. The body takes a while to heal. I was asked, what is the average time before you can get back to walking after a knee replacement? So a knee replacement is when people have bad arthritis or significant arthritis, and sometimes and people ask me all the time, what is arthritis? I hear this term arthritis. And so if I was looking at a knee, arthritis is, and if I move the kneecap out of the way, arthritis is when the blue in the knee gets worn down. It's not a buildup like tartar on your teeth. People say, can you go in and scrape the arthritis? The answer is it's not like tartar that you scrape off. Arthritis is an absence of. I tell people it's like wearing a hole in your jeans. So when you wear a hole in your jeans, you wear away this blue. And when that blue gets worn away, that's what arthritis is. And so when people get severe arthritis and they have no more cartilage, the cartilage is blue on that model, it gets to be very painful, limits people's walking. They get very stiff if they sit for a while. And so then if the point comes where they're impaired for everyday activity, we do a knee replacement, which is basically cutting the ends of the bone off and then putting metal and plastic in between. People start walking right away. Really, the next day we let them start putting weight on it, but they're using a walker or crutches. And they start to usually around the 3 to 4 week mark get rid of the assistive devices and start walking more normally. So when they get back, usually by 6 weeks they're feeling better and better. But knee replacement, again, no surgeon duplicates God's work. I say that all the time to my patients. And knee replacement's not a normal knee. It doesn't make you feel perfect. It's a little bit mechanical, and you lose some almost agility feeling in your knee. And so it takes 3 or 4 months before people kind of feel really good. And a total knee is not something you're going to run on per se. A total knee is really for walking, for cycling. You can play golf, maybe some tennis doubles. Skiing, you can do some of that, although I get nervous about people skiing because if you fall and you have a fracture above that, it becomes a very difficult thing. Another question, can you get frozen shoulder again after surgery? So frozen shoulder is a pretty common diagnosis we see, and if I'm going to pull up the shoulder model one more time. Around the ball and socket is a sphere, and that sphere is a capsule, and that capsule holds the fluid in the joint. And when frozen shoulder happens, that capsule shrinks down, and when it shrinks down, it limits the movement of the shoulder. The shoulder gets very tight. People who have frozen shoulder oftentimes have trouble putting their arm in a jacket. They have trouble reaching their hand behind their back. It's hard to throw a ball. Sometimes a quick movement, like a dog jerks on a chain, it can bother you and hurt and irritate you. And when that happens, it's difficult, it hurts. And so frozen shoulder can happen by itself, or it can happen after surgery. It can happen either primarily, and it can happen secondarily. So primary frozen shoulder usually affects women. Most of them are in the 40 to 50 range, 40 to 55 or 60-year-old range. People who have an endocrine disorder like diabetes or thyroid disease, it can affect them. And it can happen after a minor or minimal trauma. So the bad news about frozen shoulder is that it can take a long time to get well, 9 months, sometimes 12 months. The good news is it doesn't usually require surgery. But I was asked, can I get it after shoulder surgery? The answer is absolutely. Shoulder surgery is a controlled insult, if you want to think of that the way we do it with the shoulder. We do a lot of things arthroscopic through poke holes, which is minor trauma, or try to minimize our trauma, but we're still working with instruments in the shoulder. Then we put people in a sling, they get sore, they don't want to move their shoulder, and so they can develop a frozen shoulder afterwards. When that happens, we try to be patient with them. Sometimes we give them cortisone injections, but it will eventually get better, or I would say 90% of the time gets better. The percent of the time it doesn't get better, sometimes we have to stretch their arm, do a manipulation under anesthesia, as well as a host of other things. Another question I got, tennis elbow. Tennis elbow is, if I look at the elbow, it's when people get pain on the outside or on the inside of their elbow. When it's on the outside of the elbow, it's known as tennis elbow. On the inside, sort of golfer's elbow. But it's really the same thing, which is basically some tendinitis and a little bit of degeneration of the tendon called tendinosis. That's when the tendon starts to have micro tears and breaks down. When that occurs, people can be really sore. It can be hard for them to lift a gallon of milk or to turn a coffee pot or something along those lines. Having said that, like frozen shoulder, tennis elbow usually improves and gets better. It usually will, with sometimes a cortisone shot, stretching, and time, usually improving it better. But it can be a long haul for those patients, and they're pretty uncomfortable and pretty miserable. People say to me a lot, I didn't know tendonitis can hurt that much. And the answer is tendonitis can be very difficult. Another question, are shoulders a key in our posture? And what's the best way to strengthen them to help with our posture? So shoulders, the shoulder blade in particular sits on our, again, here's a model of the shoulder. Our shoulder blade sits on the rib cage in our back. And a lot of times we type and sit and we kind of get over in this hunched position. And that's just a function of being on computers and being in the office a lot. And so sometimes our posture gets to be sort of more toward the front and we kind of slouch. A lot of times we do scapular stabilization exercises, which kind of help your shoulders pull back and hold in a more normal position. That can help your shoulder function overall. There's a number of different exercises for that. There are websites. If you look up scapular strengthening exercise, or there are a lot of physical therapists who would be more than happy to give you some sheets or feedback on that. But that's certainly a way that that can help them get better posture. And it's something, home exercises or these stretching exercises or physical therapy exercises, I tell patients, it's like brushing your teeth. You have to do it a couple times a day. You can't expect to do it once with your physical therapist. You have to do it a couple times a day. So it's something that you have to stay with and work at. How soon after a biceps tear is it important to be seen for surgery? That's a really good question. So we were talking about acute tendon tears earlier. Sometimes when a tendon tears from the bone, it will pull back, it will retract, and sort of go in the wrong position. The biceps is probably the most classic for that, meaning that the biceps is a strong muscle, and when you rupture it, it tends to kind of pull up into your shoulder. We call it a Popeye muscle in terms of people walk in and they have a Popeye muscle. It's a deformity of the muscle. The muscle looks bunched up higher in the shoulder. And that's because there's no opposed pull to that tendon anymore. For a biceps tear, if we don't get to that surgery, we try to get to that within 3 weeks or so. The complication rate goes up and the irreparability goes up. So a lot of times with a biceps tear, within a week or two, we try to fix them. At 3 or 4 weeks, I have fixed them. It becomes more difficult. At 6 or 8 weeks, it's almost impossible. So that can be a difficult situation. The other thing we see that with is hamstring tears. Sometimes people pull a hamstring off their pelvis. So the classic is a sprinter or a water skier. They'll feel a pop, snap, they'll get a big bruise, and they'll have this deformity in their thigh. We try to do that within a month or so, because the longer that goes, the harder it is to pull that tendon back. That tendon gets scarred in, and when it gets scarred in, it's hard to pull that back to where it belongs. So there are time-sensitive things. I tell people it's almost like when you fall and you break your arm. You don't want your arm to heal in the wrong position, because then you have to re-break it. We hear that a lot. That's called a malunion in my world, when the bone heals in the wrong position. We don't want that to happen. So a lot of times people, when they have a fracture, they know it needs to get set, or they know it needs to get casted, or something along those lines. Tendons can be the same thing as those bones. So if you rupture a tendon and it heals in the wrong position, you can't always get it back to where it belongs. The rotator cuff that happens to. Again, the biceps and triceps are probably the ones that we have to operate on the most quickly, and the hamstring tendon. Achilles tendon is also one of those tendons that we have to do quickly. I think Christine, who's a long-term patient of mine, just said, what do you do for bursitis of the hip? That's a good question. Bursitis is, so what's a bursa? Maybe we should start with that, because sometimes we use these medical terms, and patients may not all have the same understanding of that. It's like I go to the car and I go to the garage, and the mechanic tells me about the carburetor and the idler, and I just kind of nod my head, having no idea what he's talking about. So the bursa is actually a fluid-filled sac. We have bursas over our skin. Elbow is one place where when we bend our elbow, the bursa is a fluid-filled sac upon which our skin glides. You have one in your shoulder, you have them in the knees, you have them in the ankle, but the one in the hip seems to get aggravated a lot. And so bursitis of the hip is really, if you try to lie on your side, like especially on a hard surface, people will develop pain on the hip. It's a pain directly to the side of the hip. You can almost feel the bony prominence where you are, and that's where the bursa is. People ask me all the time, I think I have hip arthritis. I've got this terrible pain, and they point to the side of their hip. Hip arthritis can present that way, but it's unusual. Hip arthritis usually is pain in your groin and down the front of your thigh. So when people have pain on the side of their hip, a lot of times it can be bursitis, and that's because there's tendons when we walk and when we sit and we climb stairs and hike that rub against the bony prominence of your hip, and when it rubs, it causes increased friction, and that bursa sac, which is again a fluid-filled sac, gets inflamed, it gets angry, it gets cranky, kind of like my kids when they're indoors too long, kind of like all of us when we feel like we're landlocked for too long or stuck in the house. And that can be really uncomfortable. The good thing about bursitis is that there's not a danger to it. It doesn't cause any permanent damage. It doesn't hurt you. It's just an achiness. It's a soreness that develops. And sometimes a cortisone shot can help. A lot of times stretching can help. Anti-inflammatory medicine can help. There are physical therapists do a lot of treatments with patients with hip bursitis. They can do foam rolling. They can stretch. There's things like iontophoresis and ultrasound, which can help that. But a lot of times the mainstay is to really try to stretch and to not do the offending activity so that we're not continuing to aggravate it. If you're training for the Boston Marathon, if you keep running, that's going to be a little bit of a problem or a little bit of a issue for that. I was also asked a question a little while about reverse shoulder replacement. People say, what is a shoulder replacement? What is a reverse shoulder replacement? So a shoulder replacement, and I'm going to pull my model up here. A shoulder replacement is when you go in and we cut the ends of the ball and the end of the socket off. And so you literally cut out, you take a saw, you cut the bone, and you take a reamer, we call it, and you grind down the socket and make it a nice smooth surface. And you put metal on the ball and plastic in the socket. That's a normal shoulder replacement. So when people talk about what's a shoulder replacement, it's when we substitute parts and make them look kind of exactly how you were born with. We make the ball a ball and we make the socket a socket. A reverse shoulder is when we do the opposite. A reverse shoulder is when you make a socket out of the ball and a ball out of the socket. And people say, that sounds crazy. Like, why would you do that? And the short answer is a conventional shoulder replacement we do when people still have the rotator cuff or the muscles attached. So the muscles, when they're attached, can still function. But when you don't have a rotator cuff and you develop arthritis, then the rotator cuff can't help move the shoulder. And so a reverse ball and socket can really help move the shoulder because it helps the deltoid, which is the larger muscle, function. And so a reverse shoulder replacement is a little more complicated, but can give people who have trouble lifting their arm and terrible arthritis some pain. I just got a note from Marion, who's a patient of mine down in Alabama, who told me to come visit in the Gulf Shores, and I should, because we're expecting snow this week, as everyone knows in New Hampshire. As my wife said, who's from Alabama, down near the Gulf Shores where Marion is, said, I can't believe the Pilgrims were silly enough to eventually hit land and then stay in Massachusetts. They should have at least got down to Virginia or somewhere warmer to make the winters better. And with snow coming this week, that's a good reminder for us. Another question, can you treat a tendon injury non-surgically? The answer is yes. Probably the best example of that is an Achilles tendon rupture. Achilles tendon ruptures, people feel a pop and a snap. There are lots of times we fix them. High-level athletes, we tend to fix them in because their explosiveness is a lot of times better with surgery. But believe it or not, Achilles tendon ruptures can be treated non-operatively, and they will heal in a cast. It's a little bit longer recovery. It can be a little bit more of a hassle. You can't wait there for as long, but they will heal, and people will do fairly well with them, which I think is an interesting scenario. People who have rotator cuff injuries, we treat a lot of small rotator cuff injuries without surgery. Do they heal? That's controversial. Partial rotator cuff injuries, meaning when part of the tendon is torn, there are some studies that suggest you will get healing. When there are full tears, they're rare to heal. They usually, or we say, won't heal. But sometimes people will tolerate a small tear and do just fine because you have 4 major rotator cuff tendons. And if 4 of the 4 tendons, if you injure one or part of one, sometimes you have 3.5 engines, so to say, to fly the plane. And if you have that much, it's helpful in terms of using your arm. You still have 3.5 tendons that'll work. I got a message from Casey. What's the hardest diagnosis you've ever had? I think probably one of the hardest diagnoses is I've had patients with Ehlers-Danlos syndrome. Ehlers-Danlos syndrome is a disease of collagen. What's collagen? Collagen is basically the building blocks of our muscle, our bone, our ligaments, and things like that. And sometimes teenagers will come in with significant injuries, and when they have significant injuries, we treat the significant injury. People with Ehlers-Danlos syndrome tend to stretch out their own tissue, though, so they tend to have instability of their shoulders, their knees, their hips, their joints. And when people have Ehlers-Danlos syndrome, they don't heal always very well, or they don't heal as well as the typical person because their tendons tend to stretch out, or their ligaments tend to stretch out. And so sometimes it's hard to make that diagnosis until there's been several occasions when things haven't gone what I would say typically as planned. And when that happens, we sort of scratch our head and say, something seems like it's not right, something seems like it's off. And so then we start talking about other causes of discomfort, pain. Sometimes we have them see geneticists. So sometimes diagnoses like that are difficult. Other diagnoses that are difficult are when the MRI, and I would just classify that as when the MRI is not accurate. MRI is a wonderful tool. It's a great tool. We use it every day. And MRI is right probably 95% of the time. Or 97% of the time. It's right a lot. But there are times that we become almost technology dependent, where we see an MRI and we say, boy, that looks really good. Boy, that looks really good. So there's not a big structural problem. And sometimes there are subtle injuries that MRI has a hard time picking up. And when MRI has a hard time picking up those things, then it becomes more of a clinical diagnosis. And so sometimes we wind up telling people, this is what I think it is, even though all the tests say something else. So we either have to repeat the MRI, or sometimes we have to inject dye into a joint to look for that. Or sometimes we put a camera in to look at a knee, or look at a shoulder, or look at an elbow or a hip to see what's going on, because it can be difficult to know those things for sure. And so while X-rays, CAT scans, MRI, there's no question that technology is useful and important and critical in everyday healthcare. It's not always perfect. And so sometimes the hard diagnosis is to say, I think this is what it is, even though all the other tests don't suggest that. And then it becomes a little more unpredictable. And when it's unpredictable, it becomes more difficult. What makes, I got a question, what makes the hips go out so that I have to go to the chiropractor? So, chiropractors, I would say this just to start with. Chiropractors and orthopedic surgeons, I think it's 20 years ago when I was training, I think had a contentious relationship. They both, I think each group thought they were doing something different and wrong. I view chiropractors, and I think everyone at Concord Orthopaedics views chiropractors, and most orthopedic surgeons these days, is we are all part of the medical team. It's a complementary group. They do soft tissue massage. They can do a lot for soft tissue and things like that that can be helpful. And they're not going to, I think, treat a broken femur, and I think they understand that too. So it's funny, I have a patient who I fixed her ACL, which I can't use her name, but she's a chiropractor, and we've had a lot of discussions just about those different things. So chiropractors do manipulation, and they do what I would call hands-on therapy to help with soft tissue, inflammation, and massage. Sometimes that feeling of a hip going out it's not truly a hip dislocating. The hip is a deep ball and socket, so it's not truly dislocating. Sometimes they use the term subluxation, where it sort of rattles around a little bit. And so what a chiropractor would be better at answering this question than I am, but I'll try my best in terms of that. A lot of times the chiropractor will try to massage the soft tissue and try to balance the muscle and try to make that glide better. But a lot of times when we talk about, or I think when they talk hips going out, it's more like it's rattling around, not truly a dislocation. A true dislocation, if anyone watched the NFL draft last night, there was an Alabama quarterback who had a true dislocation on the football field. And when that happens, it's a high energy injury, and they need to usually need surgery. I was asked, are there any non-surgical solutions for arthritis in the hands, specifically the thumbs? So CMC arthritis, and again, we use these big terms. CMC means carpal metacarpal, and so I'm going to hold up my thumb. The CMC joint is really at the base of the thumb, right here where it meets the wrist. And a lot of times people have pain from pinching, from gripping over a lifetime. They develop arthritis at that joint. Probably the most common joint in the hand that gets arthritis. And CMC arthritis is more in women than men for reasons that are not fully understood. But CMC arthritis makes pinching, gripping very painful and very sore. Non-surgical, there are definitely non-surgical solutions for that. A lot of times we put people in braces called the Futura splint, which kind of helps give their thumb some support. And then sometimes we do cortisone injections into the thumb. The thumb is a small joint, and a cortisone shot in the thumb, I will warn you, can be very sore, very painful, more so than I think a shot in the shoulder or in the knee or in the hip, which is a bigger joint. So they can be very sore and very uncomfortable. But when you get a cortisone shot in there, it tends to give people a lot of relief. People ask, what does cortisone do? Does cortisone cure arthritis? Does it melt arthritis? Does it do those things? And again, I would say arthritis, again, is not a buildup of a plaque like in your teeth. It's actually an absence of cartilage. And so when you wear away the cartilage, the lining and the tissue around the thumb get very sore and very uncomfortable, and they get a lot of inflammation. And the cortisone shot actually, I tell people, reboots the computer. It takes away all the inflammation. It tries to get you back down to your baseline working function. And it does usually a pretty good job of that temporarily, at least in the thumb for a few months. When we walk on ankles, walk on hips, walk on knees, sometimes cortisone injections don't last as long. For the upper extremities, sometimes they'll last longer. So for the thumb, sometimes that will be more helpful. I think there's another question about numbness in the thumb. Can the numbness in your hand from an ulnar nerve injury be repaired 4 years out? So in terms of numbness, I would say we should talk about two things. Numbness in these three fingers, which is your thumb, your index, and your middle finger, usually comes from the median nerve. So if I just hold my hand up like this, the median nerve runs through your palm and supplies these three fingers. It actually supplies half of your ring finger too. But these two fingers classically, the ulnar, the small pinky and the ring finger, they come from the ulnar nerve. The ulnar nerve runs through your elbow and kind of down into this area. The areas of compression are most typically for the median nerve in the wrist and for the ulnar nerve in the elbow. If an ulnar nerve has been compressed for a long period of time, almost like a hose gets kinked for a long period of time, it's hard to unkink that hose. And so sometimes there can be permanent damage to an ulnar nerve. There's a special study called an EMG. An EMG is when we look at the electrical current in that nerve. You put electrodes on and you measure how fast electrical current will go through the nerve. And that can give us some idea if there's permanent damage to the nerve or if there's only just partial damage to the nerve. In other words, is the nerve being squashed and permanently damaged? Or is the nerve being pinched, and if you unkink it or take some of the pressure off, it will be made better? So the ulnar nerve, I tell people, whether or not you'll get recovery, in part depends on the EMG. In part depends on the time. It in part depends on your age. In part depends on your other health conditions. People with diabetes have a harder time recovering nerve function because there's small vessel disease in the nerves from diabetes. And so people with carpal tunnel or cubital tunnel, which is when the ulnar nerve gets pinched in the elbow, if they're diabetic, that can be a longer recovery. So the short answer is, if people have had long-standing problems with a nerve, it sometimes can be improved or it can be helped, but not always. And it really depends on what the EMG says. Are EMGs painful? I would say yes. Anytime. An EMG is like putting a little electrode or a little needle in, and you run a little electric current. I've had patients tell me, I feel like I was touching a little bit of, small electric fences where you get that little zing. So yeah, it hurts a little bit, but the information is obviously important. People ask me all the time, do cortisone shots hurt? Are cortisone injections painful? And the short answer is, yeah, they hurt. So does the flu shot. I don't think they're any worse than, say, the flu shot. Sometimes people say, I'd rather give birth to twins than get a cortisone shot. And I would say, I think you're wrong. I've never given birth, but I've seen my wife give birth. And not that I should wade into that topic, but I have had shots, and shots seem to be much less painful than that. So I think there is a lot of anxiety and fear about shots, be them gel shots, be them cortisone shots, in terms of that. And I think that they do hurt a little bit, but it's usually just for a couple seconds and no worse than a flu shot. So I just had a patient who's a great patient, Casey, who just said, yes, they are. She has had them, and she knows probably more than any of us. I also, I'd rather get another cortisone shot than give birth to twins, which one of the athletic trainers for high school just said, and I would, again, having not given birth, I shouldn't wade into that discussion, but I would concur with her and vote that that's right. So I appreciate everyone's time and energy. Thanks for tuning in. Thanks for asking questions. If there's anything we can do at Concord Orthopaedics to help, please let us know. We're doing a lot of telemedicine these days, which I'm not sure sometimes patients don't know about. If they're elderly or they're older and they're worried about coming to the office, we're available to talk, usually on FaceTime or Google Duo or whatever method of which is easier for them. I'm not a huge social media guru, so I don't know all of them, but I use FaceTime and Google Duo mostly. And so that's an easy way to even find out if you have to come in. And call the office if there are questions. We can sometimes just get to you over the phone. But everyone stay safe, social distance. I think this too will pass. We'll all pray hard that this pandemic goes away and we'll get back to normal living. Maybe you'll give us some gratitude for the simple things like going to the movie theater, going out to eat, going to see a sporting event. I know it's changed my perspective on those things. So thank you so much. Have a good day. Have a great weekend.